Hi everyone, I welcome you all to this series of Labs to Clinics where we take your knowledge of microbiology and we take you inside clinics and see patients, integrating your knowledge of medicine, examination, history taking, and the art of ordering the diagnostic tests in order to reach microbiological diagnosis of the diseases, right? So if you have joined us, please come and say hi in the chat box. Of course, I'm willing to take any questions as we move forward. So we have covered a whole range of topics up till now in this series. We have covered how do you progress with a patient who comes to you with fever along with a rash. We have discussed a nightmarish bloody diarrhea outbreak inside the hostel of an MBBS college. Then we have also investigated a case of neonatal sepsis. So we have, and then a respiratory distress in an HIV positive patient. So many different topics we have discussed where we see how the patients present with us typically in real life, in the hospitals, in the clinics, how you're going to see these patients of infectious diseases, how you're going to have DDs in your mind, pinpoint, rule out, and come to a diagnosis while ordering the correct microbiological tests so that these tests can help you build a diagnosis and not become the confounding factors themselves, right? So, how to best use lab diagnosis to your benefit when you're trying to diagnose patients. That is the aim of this series. So today we are going to discuss a patient of fever with jaundice. Hi Bhumi, very good evening to you as well. Right. So, of course, every time you come with a patient with fever, acute febrile illness, AFI, you think of lots and lots of, diseases under the spectrum. Especially in endemic countries like India, you think of endemicity based on the states and the location where the person belongs to. But when the patient says that there is yellow discoloration of the skin and you also notice jaundice, then there is a complete shift in the diagnosis. Then there is a complete shift in what you want to diagnose. Now you know that there is some kind of Miss Antara, I don't know the right salutation to that. I think Vanakkam to you as well. Hi, very nice to see you. Well, so that is now the patient won't come to you saying like this. Okay, the patient will come to you with some chief complaints. So this patient presented to us, he said okay, he's been having fever, high grade fever for the past a week or so, 6 days, must have, I always tell you, whenever the patient says fever, you should always ask for documentation. Before you call it high grade, low grade, you should always ask for documentation, because in today's day and age, most of the patients are going to come to you after having measured the temperature. So if more than 100 degrees Fahrenheit, you know it is a high grade fever. Very warm good evening Osama, very nice to see you all. There is yellow discoloration of the eyes and urine since 3 days, and this is what the patient is going to tell you, right? And severe body ache, predominantly calves, reduced urine output for 1 day. He says that okay, he's not been passing lots of urine, there is discoloration, the body has turned yellow, and he's having high grade fever. I'm good. Right now, then it is upon you to elicit the detailed history of all of these features that the patient has told you. Up till now, you understand that the chief complaint, primary complaint of the patient is there is fever and there is jaundice. Now it is up to you to elicit what type of fever, what kind of fever, what type of jaundice, what are other associated symptoms, and you do not miss out on any important symptoms. So the fever was high grade, was continuous, no association with any periodicity. It was associated with chills but no rigors. You do understand that chills and rigors typically is for malaria, whereas chills is mostly associated with most fevers because the body temperature rises and the patient tends to feel cold. Poor response to paracetamol. Now, this is poor response to paracetamol is kind of telling you that probably this fever is not just a prodrome to some other viral infection which is going to come. Whenever we teach you virology, whenever we teach you diseases, even if we are teaching you some respiratory diseases or skin diseases, etc., even, something as fatal as rabies, it starts as a prodrome with fever. So fever is just a sign of the body to tell you that something is wrong. And most viral illnesses, whether they're respiratory illnesses, rashes, even some zoonotic diseases such as the rabies, etc., they all start with a fever. But whenever it's a prodrome, there will be a response to antipyretics. If here they are saying that there is no poor response to paracetamol, means every time they pop the bill, the fever goes down, but it rises back again. It does not get subsided for a significant period of the day. This is telling me that some systemic involvement or infectious involvement is there when the fever is refractory to paracetamol. Then jaundice, it appeared after fever onset. So the patient first had fever and then there was jaundice. That is the thing to note here, right? Progressive yellowing of sclera, so it's getting worse with time. There is dark yellow or cola colored urine. So whenever you have a patient of jaundice, it is important to ask urine output, it is important to ask the color of urine. There are two important reasons for asking these two questions. Urine output you are asking because you want to know about oliguria and you want to rule out any involvement of the renal system. You want to rule out any acute kidney injury in this patient also, because very important infectious causes of jaundice, infectious causes of infectious diseases associated with jaundice are also associated with acute kidney injury, and that can turn fatal for your patient. And the yellow colored urine that you're asking for, it is telling you whether there is conjugated bilirubin in the urine or not, which is then telling, which is your biggest indicator of whether it's a post-hepatic, obstructive, non-obstructive, what kind of a jaundice you're dealing with here, right? So over here we can see that probably it is conjugated bilirubinuria inside the patient. No pale stools, no pruritus, okay, fine. Then up till now I know that, okay, there is fever which is related to some systemic pathology, some systemic infectious cause, and jaundice is also associated, which is giving me the yellow urine. Renal symptoms are also present where there is no dysuria or flank pain. Why is this important? Because of course for decreased urine output, the first thing that you will think of is UTI. In any patient who is complaining of decreased urine output, you have to rule out UTI, especially in the male age group patient which we are dealing with here, right? And there is no flank pain, so of course no renal stones or things like that. There is no significant obstructive renal pathology here. So you are thinking that, okay, this is probably associated with this episode of jaundice. Myalgia is there, which is severe calf muscle pain. Now this is, the patient is telling you very characteristically that I have calf muscle pain, so much so that it is difficult for me to walk also. Now there are some buzzwords in medical field, especially infectious diseases and microbiology, wherein words like these, they really give you an idea about what to suspect. So, what are the first DDs of a fever with jaundice to you always? There can be any kind of hepatocellular injuries happening, or there is hemolytic anemias or hemolysis inside the body, or there might be obstructive causes, and then there might be infectious causes, right? Amongst the infectious causes, most importantly, you think of dengue. Amongst the bacterial causes, you think of, very importantly, you think of all the causes of FU also. You think of Leptospira very importantly. You think of Borrelia very importantly. The spirochete brothers, right? You think of enteric fever, which is typhoid. You have to think of these three very important bacterial causes whenever you have a patient of jaundice. And more important than bacterial, you have to think of viral causes of jaundice. So there is all the hepatitis viruses, the A, B, C, D, E, entire spectrum of hepatitis viruses becomes very important. Then many hemorrhagic fevers you have to think of, because hemorrhages can also present like that with the yellowing of the skin, etc. So you have to rule out hemolysis, hemolytic anemias, and infections, right? So this calf pain, muscle pain that the patient is telling, then it can happen in dengue, which is an important viral cause. It can happen in leptospirosis, which is a very important bacterial cause. But we are not there yet. Let's move ahead further. Let's ask the epidemiological history. Now, this is what we tend to miss out most of the time, because most of us find it boring also. Now, this guy is a sanitation worker. However, there are no animal bites. In the previous sessions, I have focused so much upon animal exposure and animal bites that I hope by now it has been drilled into your head that it is very, very important to ask the history of pets, ask the history of animal exposure, ask the history of recent travel to forested areas, and very important to ask the history of occupation, because occupations such as animal handling, animal husbandry, vets as a profession, then people who work in the farms, who have cattle, etc. Even in the previous last case that we discussed, we had the final history. When we probed further, we found out that the person was working in his uncle's dairy farm, where he got exposed to the products of parturition of cattle, and he got exposed to drinking unpasteurized milk. All of this is very significant history in your patients when they come across to you. A patient might not tell you all of this because that's just a part of his life. Then the patient is a sanitation worker. While you might not think too much about it, this is in fact going to be your biggest hint in diagnosing this case, right? Negative history, of course, you have to take history of alcohol intake. Why? Because there can be hepatocellular injury because of alcohol intake. No IV drug abuse, no blood transfusion. Why? Because we are very, very significantly want to rule out viral causes. So amongst the hepatitis spectrum, hepatitis B and C, most common modes of transmission are actually needle stick injuries, sexual transmission, and drug abuse. So blood transfusions and IV drug abuse are very important in patients of jaundice. Then no past history of jaundice in case there is any hemolytic syndrome, etc., or pathology. Good evening guys. And no known chronic liver disease. So the patient is not giving you any significant liver disease involvement or history. No cirrhosis. You can go for an ultrasound also, but history is quite explicitly telling you that this is an acute episode and most probably an infectious cause. Let's probe further. So when you examine the patient, on examination you find that there is scleral icterus present. The sclera is yellow. Conjunctival suffusion is present, whereas there is no discharge. No discharge means no pus, no watering from the eyes. So there is probably no rhinorrhea associated. We had discussed a case of measles where this conjunctival redness had completely confused us and taken us to the leptospirosis diagnosis as one of the DDs also. But what was that redness of the eyes associated with? Continuous watering from the nose and the eyes. So that was the 3 C's of measles, okay, the cough, coryza and conjunctivitis. There it was conjunctivitis and coryza in the patient. Here there is no conjunctivitis, there is no discharge in the patient, there is no coryza, cold, only redness, completely red and yellow eyes the patient has, okay. So there is redness when you look like that on the conjunctiva. When you lift the eyelid and look at the sclera of the patient, you see that there is yellow discoloration. These are very, very important markers. Then other symptoms of CVS, respiratory, CNS, everything's normal. There is no rash and there is no bleeding manifestations. Then many, many causes of viral hemorrhagic fevers, bacterial hemorrhagic fevers also can be, put on the side end for now. But you can definitely not forget about important viral causes of, jaundice. Then, when we palpated the liver, it was palpable, meaning there is hepatomegaly, liver is enlarged, whereas spleen is not enlarged and ascites is also not there. So, alcoholic liver disease, chronic liver disease, they all will present to you with ascites, that is absent. Anyways, it's an acute presentation and spleen is also not palpable. So, in many, many parasitic diseases such as malaria, leishmania, etc., there is hepatosplenomegaly. Both are enlarged because that is where the RBCs are going to die, which have been infected with the parasite, right? So only and only liver is enlarged. So what all information do you have up till now? You know that patient has fever, patient has jaundice, patient has probably conjugated bilirubin in the urine, yellow urine, conjunctival suffusion, calf pain, liver enlargement and renal dysfunction is also involved. So kidneys are also under attack. Of course, you have to prove everything with your general investigations which is done for each and every patient. So of course, you can see amongst the examination, you can see that there is fever which is telling you some active infection is there. Pulse is mild tachycardia only, which can happen in fever cases, but there's no relative bradycardia. And I keep repeating that this is very, very important for cases of typhoid, sometimes also for cases of brucellosis. Yes. Low BP, there is low BP. Patient is in early shock here. So that means it is getting affected. Respiratory rate SpO2 not so much significant. So you can rule out the involvement of the respiratory system. What? Up till now, what is our clue? High grade continuous fever. Some bacterial systemic infection. Continuous fever, high grade, not responding to paracetamol. Some systemic infection is there. Jaundice appearing after fever, infective hepatic dysfunction. Okay, it is not that first jaundice was there and then co-founding associated, there was some fever because of some other reason, and jaundice was because of some other alcoholic or heavy metal hepatocellular injury. No, it is because of some infectious cause, right? Very nice to know, study stethoscope, that you scored very good marks in second year because of the lectures. Congratulations to you. Keep up the good work. Conjunctival suffusion strongly suggests leptospirosis and severe cough myalgia is also telling you that this is probably leptospirosis compared with viral. But this is just an indication. We cannot get biased at this point because everything needs to be proven microbiologically. Oliguria is telling me renal involvement is there, which is again telling me that some leptospirosis can happen. He's a sanitation worker. Now, you remember for leptospirosis, we say the 3 R's: rain, rats, and rice fields. Yes, so if it's a sanitation worker, he's going to have exposure to what? Rodents. He is going to spend many hours of his day standing in deep stagnant waters, working in places where there might be exposure to rat urine. So it's a high risk. There is of course a high risk in the patient. No rash or bleeding, so dengue is less likely, and no splenomegaly, so malaria is less likely. Only less likely we have said based on the DDs we had. What were the DDs? Viral we had dengue and all the hepatitis. Parasite we had malaria. Bacteria we had Leptospira, Borrelia, and any other cause there might be, right? So of course, in the general examination, in the general investigations, lab investigations for each and every patient, you are going to do a CBC, you are going to do LFT, you are going to do KFT in these patients, right? So CBC is not very hugely suggestive of anything, but yes, very important to find out that any hemolysis is not there, so patient is not anemic. So it is not hemolytic anemias. It is neutrophilic TLC, which is raised TLC is again telling you bacterial infection. Platelets are normal. So, dengue, 1 week of history of fever, progressively worsening patient, platelets at least should show a falling trend. Then, we did the liver function test. Bilirubin is raised, marked hyperbilirubinemia, 9 bilirubin is there. And out of which direct is 6.8. So, it is telling you predominantly conjugated. Also, there was the cola colored, dark yellow colored urine. AST, ALT is raised, ALP is only mildly raised, which is again a marker. We did the LDH also for the patient, which was also raised. What happened then? Serum creatinine, KFT, serum creatinine raised. Patient is going into kidney injury. It is telling me a completely deranged liver and kidney of the patient, and acute injury is there, renal involvement is there. Urine examination is not very significant here, so no cause of any UTI. Either complicated, uncomplicated. Because there is kidney injury, you could also be thinking of pyelonephritis or involvement of the kidneys, which you could have seen in the urine examination. But not very significant, no, not many RBCs, not many bacteria present, not very significant. Prehepatic, in the prehepatic cases, you see the unconjugated bilirubin and raised LDH, whereas in hepatic causes, there is a mixture of raising, and in post-hepatic, you see the conjugative raised ALP. ALP is not very raised, so you can probably rule out obstructive causes. Now, I'm getting narrower and narrower to my diagnosis. Amongst the infectious causes, I can see viral hepatitis, of course, is associated with the prodrome and raised ALT, which are both present in my patient. Leptospirosis, the cough, pain and suffusion, and the history of sanitation worker is really, making me biased towards leptospirosis. Malaria less likely because anemia is not there, splenomegaly is not there. Enteric fever also needs to be proved on culture. Dengue not so much likely because thrombocytopenia is not there, and sepsis associated cholestasis, patient does no reason for the patient to go into sepsis. There is no history of hospital stay, there is no prolonged hospitalization. Patient walked into your clinic right from home. Of course, for hepatitis you have to do the hepatitis panel where you have to test for anti-HAV IgM, anti-HEV IgM, because A and E are both feco-orally transmitted hepatitis viruses which can lead to jaundice. Hepatitis B surface antigen and anti-HBC IgM. So out of all the hepatitis viruses, the antigen detection is done for hepatitis B. For all else, we do the IgM detection, right? Then for leptospirosis, remember IgM ELISA or MAT. Cat sat on a mat with my brother Lee, right? So we have already seen sat and brother in one of the cases of brucellosis that we discussed in this series itself. Then MAT is Lee. So MAT is for Leptospira. What is MAT? Microagglutination test, microscopic agglutination test. For malaria, you will send a peripheral thin and thick smear wherein they might be able to see the parasite inside the RBCs, and the rapid antigen detection test for the HRP and the pan LDH for all the species of malaria which can be found. For enteric fever, of course, in the first week you have to send blood culture. Sending a Vidal at this point of time is not of significance because Vidal is only useful in the second week, because it will take at least 7 days for the body to start producing antibodies. And in Vidal test, you are trying to find out antibodies inside the patient's sample. So you have to wait for the second week of fever at least for significant Vidal results. So in the first week, you have very high chances that if there is enteric fever, you will be able to extract Salmonella typhi in the blood cultures of the patients, right? So what came out to be positive in our patient? Of course, there is bilirubin is raised, ALT deranged, creatinine deranged, platelets normal, and Leptospira IgM is what came out to be positive. Anyways, from the history also, we were a little bit biased. And finally, the IgM also came out to be positive. What you have to realize very importantly is these antibody detection tests have some amount of cross reactivity also. That is why it is very, very important to go through this entire process of trying to diagnose the patient, because what if the patient had no symptoms, no pointers towards conjugated bilirubin, and there was really high indices telling you that there is some kind of hepatocellular injury, and anyway due to cross reactions some leptospirosis IgM has come out to be positive, that can mislead your diagnosis. That is why always ordering the test for microbiology have to be supported and backed by proper history and other investigative markers. Otherwise something or the other comes out to be positive if you just try to do a whole concoction and cocktail of diagnostic tests, and then it confuses you further, okay? But here there is no confusion because we have taken the patient very, very properly in a systematic manner, where we had come down to Leptospira based on our solid history taking an investigation, and then it became further positive, proven upon investigation. Now, what is Leptospira? You remember Leptospirosis, the severe disease is also called as the Weil's disease. So there is the mild leptospirosis and the severe leptospirosis. The severe leptospirosis is called as Weil's disease, which is also called as hepatorenal hemolytic syndrome. So there is lots of jaundice, there is liver failure, there is kidney failure. So our patient has all these three. So instead of saying that the patient has leptospirosis, what is our diagnosis now? The diagnosis here is not leptospirosis based on Leptospira IgM. The diagnosis here is Weil's disease. Why? Because there is liver failure and there is acute kidney injury also associated. So hepatorenal hemolytic syndrome is what is Weil's disease. You remember Leptospira, it is the spiral organism. Yes, it's the spiral organism. We say the boring triplets, the spirochetes, boring triplets, boring Borrelia, trip treponema, let's Leptospira. So it belongs to that family. And we of course do the dark ground microscopy, dark ground microscopy. Now the thing about leptospirosis is that it happens in two phases. Even in mild leptospirosis and even in Weil's disease, the disease progression is such that first there is the immune phase. First there is the bacteremic phase, and then there is the immune phase, right? The immune phase. So in the bacteremic phase is when you're going to find the bacteria inside the blood, and that is when the antibiotics are going to work. But in the immune phase, the bacteria goes and sits into the deeper organs, and it cannot be found in the blood, but the IgM antibodies can be detected, and the antibiotics do not show very good effect on the patient. Patient does not respond to treatments that well, right? So in this scenario, but in the urine, the Leptospira is shed. So if the patient is in this phase and you collect the urine sample of the patient and you put it under dark ground microscopy, you are able to see the spiral organisms of Leptospira showing the lashing type, flexion extension type, or corkscrew rotating type of motility, right? Then, of course, the very important NEET competitive exam question, what is the culture media? So it's the EMJH, Ellinghausen, McAuliffe, Johnson, Harris. Ellinghausen, McAuliffe, Johnson, Harris medium, and there is also, which is the liquid medium, and then there's also the Korthof's medium, which is used for diagnosis of Leptospira. So for leptospirosis, you have to remember the 3 R's, the RRR, that is the rice, rain, and the rice field rain and rat urine, Weil's disease, bacteremic phase, immune phase, dark ground microscopy, spiral morphology, EMJH medium, Korthof's medium, and the MAT and IgM. Okay, so you can do the lept IgM, the Leptospira IgM, and you can do the MAT, microscopic agglutination test, which is in fact a gold standard. Right? All the important points about Leptospira we've been able to revise. What is the species? The very important species, because the ends of Leptospira, they look like hooked, like that of a question mark. They have the umbrella like hooked ends or the question mark like hooked ends. That is why it is Leptospira interrogens. Leptospira interrogens is the most common cause of disease. Of course, there are serotypes. Leptospira interrogens, var australis, var pomona, var andamana. From this, you have to remember it is also called as the Andaman hemorrhagic fever. Andaman hemorrhagic fever. Okay, all of the important pointers for MCQs all summed up in a single slide for you. Then based on this diagnosis, you have to perform the specific treatment. For mild cases, we give doxycycline, but for severe cases, we have to give IV penicillin or ceftriaxone. Support is to be given oral, IV fluid therapy, renal monitoring for the LFT, for the KFT, and dialysis if needed. If there is acute kidney injury and loss of kidney function, then dialysis also may be required. So whenever you have a suspected leptospirosis from clinical data or lab results, you have to see whether it's in the septicemic phase or in the immune phase. Septicemic phase or bacteremic phase means the same thing, right? If it is in the bacteremic phase, you send the blood culture or the PCR. Very difficult to extract Leptospira from blood cultures. So best methodology would be to do a PCR. PCR in this patient, sending the blood. You will find the bacteria in the blood. In the immune phase, you have to go for rapid tests. If they are negative, you repeat after 3 days. Okay. And then if they come out to be positive, you go for MAT, the microscopic agglutination test, which is the gold standard, also the confirmatory. If IgM is positive, what is this rapid test? It is the IgM, the Leptospira IgM, which we did in our patient. MAT has to have a 4-fold rise in titer or a single titer of more than 1:400. What is more important is the 4-fold rise in titer. Like I said, there might be very many false positives with IgM results. So if you do microscopic agglutination and you see that the titers of today and then done after repeated after 1 week, there is a 4-fold rise, that is going to tell you that it's an acute infection. Okay, right. Fever plus jaundice. So whenever you get a case of fever plus jaundice, you have to do a classify the jaundice first, whether it is hepatic, post-hepatic, pre-hepatic, obstructive, what kind of a bilirubin is coming out. Look for red flags such as bleeding or acute kidney injury which was present in our patient. Narrow down to infectious causes based on all of this history. Order targeted microbiological test. Start early empirical therapy and modify based on the results. So even if you had started broad spectrum antibiotics in this patient, even if you had started thinking on the lines of dengue fever or viral hepatitis, then based on the lab results, you have to modify and start the patient on doxycycline or penicillin, wherein you might be giving cefepime and whatnot, all the third generation cephalosporins, of course, while thinking about any other bacterial cause, right? So take home is jaundice is not a diagnosis, it's a clue, and microbiology connects the bedside findings to etiology, therefore giving specific therapy and saving the lives of the patients. And I always tell you, this is where you can contact me in case of any doubts. I'm always available. So thanks so much for joining and staying in the game. Thank you guys. Of course, I'm going to see you very soon in the next session, wherein we discuss another interesting case, integrating the knowledge of medicine, history taking, investigations with the knowledge of microbiology, covering one important aspect of microbiology in the process. So thank you guys. Have a good night and bye-bye. Nice.